Hello, this is JD Lovell. I am speaking today about Williams syndrome for Psych 601, Psychology of Intellectual and Neurodevelopmental. The following is the outline for this Williams syndrome presentation. First, I'll describe the condition and its prevalence, define the etiology, discuss symptoms and features, describe the physical characteristics of Williams syndrome individuals, talk about some developmental delays, describe some weaknesses and strengths that individuals with Williams syndrome possess. Also talk about and describe the diagnosis, treatment. We will also discuss a case profile, and I'll provide you with some resources, and we'll end with some fun questions to consider. Williams syndrome, also known as Williams-Beuren syndrome or Elfman-Facies syndrome, is a rare neurodevelopmental genetic condition that's characterized by many symptoms, including unique physical features, delayed development, cognitive challenges, and cardiovascular abnormalities. Williams syndrome may even cause poor growth in childhood, and most adults with this condition are shorter than average. They do have a normal life expectancy, and Williams syndrome can also cause endocrine concerns like having too much calcium in your blood and urine, and underactive thyroid and early puberty as some of the side effects. The prevalence of Williams syndrome globally is 1 in 7,500 to 18,000 people being affected. In the United States, it would be on average 1 to every 10,000. Williams syndrome usually occurs when someone is missing a small piece of chromosome number 7. So this means that most people with Williams syndrome have not inherited the condition from a parent. People with Williams syndrome have a 50% chance of passing the condition on to their children. Williams syndrome may cause symptoms that range in severity, so not all people with Williams syndrome will have the same set of symptoms. So symptoms of Williams syndrome include chronic ear infections and/or hearing loss, dental abnormalities such as poor enamel and small or missing teeth, elevated calcium levels in their blood, endocrine abnormalities, so hypothyroidism, early puberty, and diabetes in adulthood, farsightedness, feeding difficulties in infancy, scoliosis, which is the curvature of the spine, sleep problems, and having unsteady walk in their gait. So many of the symptoms of Williams syndrome occur in other conditions that are not Williams syndrome and could lead to multiple diagnoses as a result. A symptom of Williams syndrome is the unique physical characteristics that are present within an individual, and it's seen as being full cheeks, large ears, prominent lips, short stature, small jaw, an upward turned nose, vertical skin folds that cover the inner corner of the eyes. This is referred to as epicanthal folds, and they also possess a wide mouth, giving them that elf-like features and characteristics. Symptoms of Williams syndrome can cause delays for children to reach developmental milestones. Some of these delay milestones include learning, so that you may see mild to moderate intellectual challenges resulting, saying their first words and talking, sitting and walking from a low body tone, which is referred to as hypotonia, and also socializing. So they have an outgoing and very, very friendly personality, difficulty identifying strangers because nobody's a stranger to them, and they have attention problems, excessive empathy, phobias, or anxiety may result, but very, very friendly, loving people. People with Williams syndrome typically have difficulty with visual spatial tasks such as drawing and assembling puzzles. They are also very impulsive and have short attention spans. They do well on tasks that involve spoken language. They have a very expressive vocabulary. They are musical, and they benefit from learning by repetition. A lot of times these individuals are seen as being extremely outgoing, engaging, very sympathetic with other people's emotions, and have an extreme interest in people. Williams syndrome is typically diagnosed when a child is a baby or early during their childhood. If a healthcare provider suspects a child has Williams syndrome, they will provide a physical examination of the child followed by genetic testing, and will do blood tests to identify gene differences in that chromosome 7. Often, healthcare providers may ask for additional tests to confirm the diagnosis and check the symptoms of the condition. And so other tests would include an EKG or echocardiogram, so an ultrasound of the heart to check the heart for irregularities. Also, they may provide a check for child's blood pressure for abnormalities, and test a sample of the child's blood or urine to identify symptoms in the child's kidneys. So if someone has Williams syndrome based on the physical findings and characteristics and or a positive genetic test results, then the healthcare provider will work with appropriate specialists to help explain the diagnosis to the family, and many times it's beneficial to have a genetic counselor on hand to help with the explanation. The provider will also discuss condition management recommendations based on the diagnosis. So although there is really no cure for Williams syndrome, it's important to identify and treat the side effects that can occur with this condition. So treatments and interventions must be based on the unique needs of each individual. And some of these may include obtaining a formal evaluation by a cardiologist. So if a problem is found in the individual's heart, the cardiologist will determine the best treatment. It's extremely beneficial to enroll in early intervention programs, therapies, or special education to alleviate developmental delays and or learning problems. There is really a benefit as well to visiting a nutritionist or a nephrologist to treat elevated blood calcium levels. And, there may be other situations where visiting specialists as needed to address any additional symptoms. So here is a case profile of a young man named Brian. Brian is a 9-year-old black male in the 4th grade. He wears glasses, has an awkward gait, and has fine motor problems. He would love to be a preacher one day and has a beautiful singing voice. The referral concerns are social behaviors. He loves people and has a strong desire to have friends, but because of anxiety and being anxious, he experiences numerous peer difficulties and then withdrawals socially. He also struggles with basic math concepts. Brian's family background is that he lives with his father and paternal grandparents. His grandmother is heavily involved in his life. He does get to visit his mother 2 or 3 times a month, and there was not a record of his parents being married previously to each other. The referral concerns from the grandmother was, in particular, his struggles with finishing puzzles and his increasingly frustration in social interaction with his peers. She was also a little concerned about his fantasy with being a preacher. The data collection, looking at different things that stood out in his historical record, were things like he did achieve his gross motor milestones, but the fine motor skills were still problematic for him. There was a extreme sensitivity to high frequency sounds. He did have an amazing pitch when it came to singing, but he overreacted when he had sounds that were high pitched, and that brought him covering up his ears. And he was previously assessed prior to his 5th birthday and again at 6 years, 6 months. During the assessment, some observations that were evident was first just observing his physical characteristics. He was short in stature, he had pronounced eyes, puffiness around his eyes, a short nose with a broad tip, full cheeks, broad forehead, very narrow and slight jaw, and large earlobes. During the assessment, he was very restless and moved constantly and preferred to stand up more than sitting down. The DOS-2 was given to assess his cognitive abilities. Regarding general conceptual ability, he scored a standard score of 70. Verbal reasoning was an 84. Nonverbal reasoning, 72. With regards to his academic achievement, the Wyatt-3 was given, and his oral reading fluency was a 76, reading comprehension 60, math problem solving 54, numerical operations 60, and spelling 63. His adaptive behavior skills was assessed using the ABOS-3. It resulted in total social adaptation, the teacher rating him at a 95, grandmother 107. Practical adaptive, 89 from his teacher, 101 from his grandmother. Total concepts, 61 from his teacher, 55 from his grandmother. And overall, general adaptive composite, an 84 from his teacher and 80 from his grandmother. The Connors was given to assess his attention ability. The teacher rated him to have clinically significant in the area of inattention and was at risk with regards to hyperactivity. However, his grandmother had no significant concerns. Following is a summary of the psychologist's findings. So based on Brian's physical features, intellectual and adaptive profile, his musical ability, and his intense interest and desire for social connectivity, suggests the diagnosis for Williams syndrome. Also, intellectual development disorder being moderate due to him meeting the criteria of the conceptual, social, and practical domains of intellectual development disorder. A specific learning disorder with impairment in mathematics, specifically number sense, being severe. Attention deficit hyperactivity disorder, predominantly hyperactive impulsive, mild, based on the teacher ratings of him being clinically significant in the area of inattention and in the at-risk for hyperactivity. Developmental coordination disorder regarding his fine motor skills as well, being needed to address. And he would also have a specific phobia regarding loud sounds. The treatment plan for Brian would first involve a health intervention regarding him being provided a complete cardiology workup because of the light heart murmur that was reported earlier. Academic interventions would first, because he does qualify for IDA because of intellectual development disorder and a specific learning disability in math and a developmental coordination disorder, he would receive special education services that would address specifically developing that number sense and basic math concepts. He would benefit greatly in occupational therapy to address his visual spatial reasoning weaknesses, handwriting, and problematic fine motor skills. Also working on just writing, buttoning his clothes, tying his shoes. These would be things that would be, part of the plan with the occupational therapy. Physical therapy, it would be important to treat just addressing his awkward gait, and that would be done through physical therapy. Because there's a disconnect between his social desires and the outcomes of his relationship, social skills training would also be provided in order to strengthen those areas to help with his social interaction. Following are helpful resources that I found. I really like the Williams Syndrome Association's website. It just an amazing resources and brought forth great referrals and and just guidance for families with children with Williams syndrome. Also, the Cleveland Clinic, Medline Plus, and Stanford Medicine Children Health provide great information regarding just understanding what Williams syndrome is all about. So now it's time to check your knowledge. First question here: what is the chance of an individual with Williams syndrome passing the condition on to their children? Is it A, 0%, B, 100%, C, 50%, D, 75%? There would be a 50% chance. The answer would be C. All right, next question here. What genetic deformity causes Williams syndrome? Is it A, missing a small piece of chromosome 7 that results in missing more than 25 genes? B, unhealthy mitochondria? C, an extra Y chromosome? D, too many genes on the 86th chromosome? The answer would be A. That missing that small piece of chromosome 7 is the key factor. And not having those 25 genes results in all these physical characteristics and cognitive areas as well. Which is not a symptom or feature of Williams syndrome? Is it A, dental abnormalities? B, too much iron in the blood? D, endocrine abnormalities? Or D, unsteady walk? Too much iron in the blood is not a symptom of Williams syndrome, but too much calcium in the blood is. Which are physical characteristics of Williams syndrome? A, the individual would have full cheeks, large ears, and prominent lips, or short stature, small jaw, upturned nose, and wide mouth, or vertical skin folds that cover inner corner of the eyes, or would it be all of the above? All of the above would be the correct answer. An individual with Williams syndrome typically has all of these different physical characteristics. And our last question here is, what is a typical strength seen in an individual with Williams syndrome? A, their ability to do visual spatial tasks. B, they love people, which is an extreme interest in people. C, drawing. Or D, assembling puzzles. The answer would be B. Williams syndrome individuals love people, and it's an extreme interest in people. They want to be around you and ask questions and talk to you. They just love you. And in conclusion, here are the references that I used in the Williams syndrome presentation.